Good morning, everyone. I am Shunabu. Today I am going to present a seminar on physical examination of urine. Physical examination of urine is an important part of urine analysis and helps in diagnosis various diseases. Let us begin. Clinical role and context. An introduction to how physical examination acts as immediate microscopic diagnostics of systemic health. Physical examination of urine gives immediate information about a person's health. It helps doctors identify kidney disease, metabolic disorders, and other health conditions. It is a simple and cost-effective diagnostic method. The value of physical urinalysis. Primary screening acts as an efficient, highly cost-effective first-line screening tool for kidney function, systemic metabolic conditions, and hepatic disorders. Immediate clues. Visual and sensory parameters provide vital clinical indicators instantly, providing direction before chemical or microscopic confirmation. Quality assurance helps assess specimen integrity, concentration, and flags potential and samples contaminated or decomposition before detailed processing. Physical urinalysis is used as a primary screening tool. It provides quick clinical clues before chemical and microscopic tests are performed. It also helps in checking the quality and integrity of the urine sample. The complete urinalysis trial. Physical examination evaluates the microscopic qualities of the sample, including dairy output volume, coloration, transparency, clarity, specific gravity, characteristic odor, and foaming properties. Chemical and microscopic analysis. Dipstick assessment measures molecular biomarkers, protein, glucose, ketone, bilirubin. In microscopic sediments, evaluates, reveals cells, casts, crystals, and microbial entities. Urinalysis consists of three parts: physical examination, chemical examination, and microscopic examination. Physical examination studies volume, color, clarity, specific gravity, odor, and form. Chemical and microscopic examinations provide further details about urine composition, urine volume, and production. Understanding renal hemostatic balance, baseline production rates, and systemic volume variations. Urine volume reflects a balance between fluid intake and fluid loss. Changes in urine volume may indicate diseases, dehydration, or other medical conditions. Physical parameters overview. Volume. Evaluating 24-hour collection yields to identify output fluctuations, color and clarity, visual checks for hydration, status, and pathogenic solutes. Specific gravity, measuring the overall solute to water ratio via refractometry, order and film. Analyzing physical markers for metabolic protein signals. The main physical parameter of urine are volume, clarity, specific gravity, odor, and forms. These parameters provide useful information about a person's health status. Physiology of urine volume. Daily baseline output. Normal physiology adult daily output ranges between 750 ml to and 2000 ml per 24 hours. The exact output fluctuates heavily based on fluid intake, ambient temperature, sweat rates, and blood pressure. Methods of assessment. An accurate assessment of volume requires a timed, complete 24 collection vessel. This mitigates transient fluctuations and allows reliable mathematical calculation of renal clearance. Normally, adult produces 750 to 2000 milliliters of urine per day. Urine output depends on fluid intake, environmental temperature, sweating, and blood pressure. Clinical volume classification. Volume indicates states like diabetes, oliguria, less than 400 ml per day signals shock or renal ischemia, and anuria, less than 50 ml per day once a acute tubular necrosis of severe blockage. Normal urine output is about 1500 milliliters per day. Polyuria means excessive urine production. Oliguria means decreased urine output. Anuria means almost complete absence of urine production. These conditions may indicate serious medical problems. Urine color and pigments. Exploring the biological origins of physiological color variations and clinical color shifts. Urine color depends on different pigments present in urine. Changes in color may occur due to diseases, medications, or hereditary factors. Biological origin of urine color. Physiological pigmentation. The characteristic golden yellow color of normal urine is primarily caused by the lipid soluble pigment urochrome, urobilin, produced constantly during metabolic cellular breakdown. Additional pigment contributions include urethane, a pink-colored pigment that naturally deposits on acid crystals and durable, an orange or brown pigment derived from oxidation. The shade correlates directly to hydration. Dilute sample look virtually like clear water, whereas high concentration presents as a dark amber color. The normal yellow color of urine is mainly due to pigment colored urochrome. Dark urine usually indicates dehydration, while very pale urine may indicate overhydration. Examples of color variations: red or pink hue common indicate hematuria, calculi, UTI, malignancy, or hemoglobinuria. Non-pathological causes include detailed dietary beats or rifampin therapy. Dark orange hue, highly indicative of bilirubinuria, indicating liver pathology of biliary blockage, also present in extreme dehydration or primordium usage. Brown or black hue, associated with alkaptonuria, homogenistic acid oxidation, malnuria in metastatic melanoma, or methemoglobinemia from tissue necrosis. Red or pink urine may be caused by blood in urine, urinary tract infection, kidney stones, or certain foods such as beetroot. Dark orange urine may occur in liver disease, dehydration, or due to some medication. Urine color reference guide. Different urine colors have different clinical meanings. Yellow is usually normal. Red or pink may indicate bleeding. Dark orange may indicate liver disease. Blue or green urine may color occur due to certain infections or medications. Milky white urine may indicate pus or lymph in urine. Appearance, clarity, and turbidity. Analyzing suspended particles, precipitates, and transparency in diagnostic clinical samples. The appearance of urine is assessed by observing its clarity. Normal urine is usually clear. Cloudy urine may indicate infection or presence of abnormal substances. Evaluating sample clarity. Normal transparency. Fleshy voided, healthy urine is completely clear and transparent. All cells are entirely dissolved. A slight haziness may develop upon standing due to cellular debris, rating which is generally not clinically significant. Physical, physiological precipitation. Temperature drops and shift in pH trigger on pathological salt precipitates. Acidic urine precipitate amorphous urates, whereas alkaline urine precipitates amorphous phosphates. Fresh urine is normally clear and transparent. Sometimes urine becomes cloudy due to precipitation of salts when it is standing. This may not always indicate disease. Pathological causes of turbidity. White blood cells, pyuria. High concentration of pus cells from a cloudy or turbid appearance, indicating active bacterial infection or severe inflammation. Red blood cell, hematuria. Intact erythrocyte impact a smoky, hazy or overtly toward pink to red presentation depending on the severity of the bleeding. Crystals and cast. Pathogenic crystals like calcium oxalate or uric acid or extensive cellular granular cysts scatter light, generating severe turbidity. Microbial proliferation. High bacterial counts or yeast, candida in active infection cause consistent thick turbidity that does not clear upon warming or centrifugation. Cloudy urine may be caused by white blood cells, red blood cells, bacteria, crystals, or cause. These findings often indicate infection, inflammation, or kidney diseases. Specific rate and concentrating power. Evaluating renal osmolarity function through mass density physical metrics. Specific gravity measures the concentration of dissolved substance in urine. It helps assess the concentrating ability of the kidneys. Urine specific gravity. Defining salt concentration. Specific gravity compares the mass density of urine against an equal volume of the pure water. Specific gravity is equal to density of urine divided by density of water. Normal values fluctuates between 1.003 and 1.035. Constant readings fixed at 1.010 indicates loss of renal concentrating and diluting capacity, pointing directly to chronic renal disease. The normal specific gravity ranges from about 1.003 to 1.035. High values indicates concentrated urine, while low values indicate dilute urine. Urine specific gravity across clinical states. Specific gravity drops towards water 1.001 in diabetes insipidus or overhydration, rises significantly during severe hydration, and peaks heavily with massive glycosuria proteinuria. Specific decreases in conditions such as diabetes insipidus and overhydration. It increases in hydration, dehydration, diabetes mellitus, and proteinuria. Qualitative traits and order form. Sensory microscopic indicators of metabolic disorders, bacterial decomposition, and structural protein leaks. The odor and form of urine can provide important clinical information. Abdominal odor and persistent may indicate diseases. Diagnostic volatile urine odors, pole or ammonical, indicates active bacterial conversion of urea to ammonia in UTIs or occur naturally when standard specimens are left stagnant at room temperature. Fruity and sweet, caused by volatile ketones such as acetoacetic acid and acetone, highly indicative of diabetic ketoacidosis. Intense fasting or severe starvation. Mosey and genetic clues. A classic musty or mosey odor is associated with untreated phenylketonuria. Distinct maple syrup like odors point to maple syrup urine diseases. A foul or ammonical odor may indicate urinary tract infection. A fruity odor is commonly seen in diabetic ketoacidosis. A mosey odor may be seen in phenylketonuria. Analyzing phone stability. Physiological form. Normal healthy urine forms a moderate volume of surface bubbles during voiding, which rapidly dissipates upon standing. Pathological variations. Thick stable white foam. A persistent thick layer of white foam that remains stable is primarily physical sign of proteinuria, signaling low blood damage. Yellow green foam. Vegetation that produces colored yellow green or orange hued form indicates pathological levels of conjugated bilirubin, signifying liver dysfunction or bile blockage. Normal urine produces foam that disappears quickly. Persistent white foam may indicate proteinuria. Yellow or green foam may occur in bilirubin area. Thank you.